Okay, now we're going to hear again from a smaller hospital where we have Kathy Ellis and Kathy Story. Kathy Ellis is the resource nurse for their inpatient services and the patient safety officer. And Kathy Story is a registered nurse at Alexandra, but she was also the patient educator when we were implementing HOBIC at Alexandra.
We're a 35-bed acute care hospital that's been in operation for over 100 years now. We're located in Ingersoll. So down the 401 towards London. We're part of the Southwest LHIN. And we have a 24/7 eMERGE service. We provide inpatient care, diagnostics, and labs. Large outpatient rehab population with some day surgery and a variety of clinics. We have about 19,500 ER visits a year, 717 acute care admissions. Unfortunately, some of our admissions never see us on the inpatient floor, 6 about per year. I know that's not a big deal. In a large hospital, you probably see 6 in an hour, but in a small hospital where everybody knows everybody's mother and father, 6 can cause a bit of an issue for us. About 12 admits a year within 30 days, and our acute length of stay is about 7.4 days.
So we jumped on the HOBIC train in 2009 along with Diane from Campbellford as a quality initiative improvement. And we are aligned with the quality and strategic planning, implementation of best practice guidelines, and senior-friendly care. So more comprehensive admission assessment. So every nurse in our facility is trained to do HOBIC from eMERGE right up to 3rd floor. So when we do that admission, it's totally done. If they're admitted in eMERGE, it comes up to us and we have to do nothing because the admission is totally done. So when it's on the floor, we have the whole entire assessment right there in front of us. So we can improve communication amongst the healthcare team. So when, say, physio comes up to the floor, they can flip open the Cardex, that assessment is right there, and they can check things out from there. So the keys to successful implementation is a nurse champion, which is myself, Kathy, and we also have an IT tech in our hospital who is a nurse. She unfortunately was injured and moved from her nursing duties to tech duties, which works out really well for us. Our senior leadership is on board with HOBIC totally. They're great. Our director of nursing is in on most of our meetings and she's up on what's going on and we've had no problem. We are a 1-floor unit, so we have 35 beds, so we're bigger than you.
By 1.
4 of those beds being special care where cardiac monitored patients are. The assessments are completed on patients admitted to the ER, so say a patient comes in, the decision is made to admit them. Our ER nurses will do that in ER most of the time. We're pretty lucky. So there's only 1 document to do. It's pretty easy, and that comes up to the floor with them. And each nurse that is employed by Alexandra Hospital goes through their HOBIC training. So everybody has the same amount of training and they're all on board. So it's just part of their job at Alexandra Hospital. Okay, so when we do our HOBIC assessment, referrals are sent to CCAC, community care partners, and pharmacy. So we're all on board. Everybody has the same exact information as the nurses on the floor. So we print out our HOBIC admission. That goes in a binder along with a face sheet of patient information, and that is part of our nursing Cardex. So we update as we go along on that, on the HOBIC admission itself. So that works as our care plan. So we can implement strategies to prevent functional decline, so you can update things on that. If the patient seems to be going downhill, you can go back, change the dressing directions and that sort of thing on that Cardex. So everybody keeps up to date. And it also identifies patients at risk for falls and confusion, et cetera. So we have little signs that we put at their bedside if they're a risk for fall, or We do have a special room, actually, that has a soft floor. That's our risk for falls room. So if a patient is identified as having a risk for falls, if there's availability for that bed in that room, then that's where they can go. And, oh, me again. What we do with our results. We provide the physician with a copy of the HOBIC discharge assessment at discharge to improve communication between the caregivers. So when we do our discharge, our HOBIC discharge, we print out 3 copies. One goes on the chart down to medical records. One goes home with the patient, so they have the information right in front of them. And one goes also back down to medical records, where each doctor in our facility has a mailbox, and medical records puts a copy of that in the doctor's mailbox, and then they pick it up. So we're all on the same page. We're a senior-friendly care falls and continence, senior-friendly care falls and continence. We are an aging population. Our medium age is probably between 70 and 90. If we get a 60-year-old on the floor, we think we have a pediatric. But anyway, so we do concentrate on those 2 things, and we're doing quite well with it, I think. Program planning and care management. Our little group gets together, and we use that care plan, and we have little meetings with family members. We involve the patient, so everybody's on board with what's going on with their plan of care. Gradual introduction of best practice guidelines and programs that apply to our patient population. And I'm sort of repeating myself here. Okay, now you're on.
So in December of this year, as part of our quality improvement plan and our senior-friendly initiatives, in partnership with CCAC, we started to adopt the home first philosophy. So when the patients come in, we no longer tend to hang on to them for 30, 40, 50 days. We're planning to send them home as soon as we can in a safe fashion. So as other hospitals in the province have adopted this home first strategy, we, along with 4 other hospitals in our region, have done the same. However, we are the only one of the 5 in our region that use HOBIC. So we kind of ran with that and thought, you know what, we've had such great luck with reducing our readmission rates and really engaging our frontline staff with the HOBIC theories and philosophies, that we thought we're going to marry this into our home first philosophy. So we've always had an interdisciplinary approach to our discharge planning, but we only did our grand rounds once a week on Tuesdays. So we thought, you know what, to improve our effectiveness and facilitate earlier discharges, we're going to do our rounds on Tuesdays and Thursdays. We have a very small team. We only have our pharmacist on site 2 days a week. And we have one physiotherapist who looks after the whole 35 inpatient wards. So better utilization of her time and great utilization of the pharmacist. We thought if we just did it on Tuesdays and Thursdays to start to see what we can come up with. So what do we talk about? We talk about the patient's ADLs, and we talk about their therapeutic self-care. 2 really key things to decide, can the patient go home safely, and what resources and amount of supports do they need in the community to go home?
So our activities of daily living. Falls, I told you a little about what we're doing with our falls routine. Personal care requirements, we discuss all that to see what they need to help them care for their own person. Continence, we go through that. Is there anything medical we can do to help you out with your incontinence problem? Is there products that can be used? We discuss all of that with the patient and keep them up to speed. Meal preparation, we ask them, are you able to cook your own meals at home? If the answer is no, then we'll figure out how to get meals for you. Therapeutic self-care, medication management. This has gone over several times today, but we want to make sure they know what they're taking, what the pills are for.
My bag, I fell asleep.
Wake up. Do they know the signs and symptoms? Do they know when to say something to somebody, how to take their pills, all that sort of stuff. So we go over that pretty intensely on discharge, especially. Do they have knowledge of their condition? Are they able to deal with their symptoms, let somebody know, that sort of thing? And are they safe? Is their house set up properly? Scatter mats? Do we need grab bars, that sort of thing? We talk about that with them, and that's all dealt with again before they are discharged. And the ability to perform regular activities, we assess that as well on admission and discharge. And you're back on.
So these conversations during our rounds really generate, if the patient doesn't understand their medications, what can we do to help with that? Do they need a community pharmacy referral when they go home? Do they need something as simple as just a doset to organize those meds a little bit better for them? And if it's their family that's going to be responsible for giving their medications, that's when we would start to involve them, because they really need to be informed as well. So as a team, we look at where's the most appropriate discharge destination for them, and it could be home, it could be to long-term care. We try to avoid long-term care conversations as much as we can in the home first philosophy, but we do recognize that some people just cannot be cared for safely in their home, so that would be their destination. But we really look at all of the ways and means that we can to avoid that destination from our organization. And to measure our successes, we needed to look at what metrics do we want to look at. So we certainly wanted to look at changes in our acute length of stay. We'd really like to see that go down. Reducing our number of ALC designations, and keeping our readmission rates down. Patient satisfaction is really key. So CCAC does do an interview with the patient post-discharge. They phone them and go through a series of questions with them about how they felt the discharge was from our organization. And just some feedback from a meeting I was at yesterday, a couple of the comments were that they felt that the nurses really knew the patient. So we really got a good flavor for what their needs were when they went home. And I think that's attributed to HOBIC, because that's something that the CCAC shared with us that they're not hearing from our sister hospitals in our county who aren't using HOBIC. So that was kind of kudos for our team. And we certainly do team teleconferences with the community care providers before they go home, and we share the HOBIC information that we have. If we have any thoughts that the patient's not going to be able to manage their medications, or there's any safety issues, we're certainly not shy to share that information with them. And I think in this whole collaboration, besides the fact that we do share that information with the physicians, we will be sharing it with our CCAC partners as well, because we've certainly seen value in that sharing of communication with our physicians. And some other things that we'll be looking at in the future are then our numbers of admissions and discharges from the emergency department. We're hoping that as we're moving people through our facility quicker, we won't have to have patients waiting in the emergency department. And just looking at some improvement in our HOBIC scores in the therapeutic self-care, because those conversations are really starting to engage our frontline staff in looking at the value of getting that information and how to use it. So that's the end of our presentation.
I don't know about the rest of you, but I'm moving to Ingersoll.
Come on down.
So this is an enormous use of HOBIC in larger communities. If you can see any of the opportunities to do some of the things that I think are enhanced by the size of your facility and the smallness of the community because of the relationships you have with other organizations in the community. But you see an opportunity to really transfer. I've heard you say in a meeting, you talked about the fact that you made a copy of the HOBIC discharge and it went to each physician, and nurses made notes on it if there were, if they were concerned about the patient's understanding of something and that the physician really needed to check that up. I don't know how possible that is in larger facilities. I think at Toronto General, I don't know, probably possible, but would need much more working out. Yes, please stand up.
What do they do with it? They actually, I had my mother in the hospital, and she took her. When she went to her primary caregiver, I went with her, and she pulled out the discharge assessment and discussed it because there were some safety concerns with my mother. So I know personally they do that. I've also heard some of our physicians are a little angry if they don't have that discharge. They like it. They like to know if there's something that we're concerned about with their patient.
Okay, well, Kathy and Kathy, thank you very much.